So I thought I'd do you guys a very quick video because I did one in pediatrics on how to review pediatric patients. This is another one in obstetrics and gynecology, specifically just on the obstetric side. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at how to present an obstetric patient. If you haven't yet subscribed to the channel, please hit the subscribe button so that you never miss on such amazing content every time I post. Drop a comment, drop a like to Zambia and beyond, grab a piece of paper and your pen, and let's go. So just a few things before we actually go in. Remember that obstetrics is actually derived from the Latin word meaning obster, meaning to stand by. So it's actually a surgical specialty that's going to be dealing with the care of women and their children during pregnancy, which is a prenatal period, during childbirth or around the childbirth, that's the perinatal period, and the postnatal period, which is roughly around 6 weeks after birth. And remember that this is actually a very unique branch of medicine because it's going to be dealing with more than one human being at a time. So it's going to be dealing with the pregnant woman herself, that's a parturient, as well as the fetus or fetuses that she's carrying. So some important terminology that I want you to be wary of. So the first one is gravidity. So this is just simply the total number of pregnancies, including the current one, irrespective of the outcome of the pregnancy, whether it was an abortion, whether it was a delivery, a stillbirth, or whatever the outcome may be. And remember that the abnormal pregnancies such as molar and ectopics are often counted. And if it's a twin pregnancy, for example, we count it as one. So if a woman actually gets pregnant and it ends up being twins or triplets, it's still going to be G1 because the person doesn't get pregnant more than once. Even when they have a twin pregnancy, it's usually just one time. I don't know if you understand what I'm talking about. Then nulligravida is a woman who is not currently pregnant. Primigravida is a woman who is currently pregnant for the first time, and multigravida is a woman who's pregnant but not for the first time, so they've been pregnant before. Then when you talk about parity, this is just simply the total number of pregnancies that this woman has carried past the age of viability. Remember, the age of viability varies with different organizations, different countries, but generally with the WHO, it's put at a benchmark of 24 weeks. So a woman that has carried a pregnancy beyond 24 weeks, regardless of the outcome, whether the child is born alive or it's a stillbirth. But some literature use a threshold of 20 weeks, others use a threshold of 28. But for the rest of this lecture, we'll be using a threshold of 24 weeks. Then nulliparous woman or nullipara is a woman who has never carried a pregnancy achieving more than 24 weeks of gestation, so hasn't carried a pregnancy to the age of viability. Primiparous woman is a woman that's carrying the pregnancy for the first time, or this pregnancy has been carried for the first time beyond 24 weeks of gestation. Then multiparous woman is a woman, or multipara is a woman that has carried more than one pregnancy beyond the age of viability, beyond our 24 weeks of gestation. A parturient is a woman who's in labor, and the puerperium or the purpura is a woman that has just given birth within 6 weeks, and the puerperium is the period after birth, so that's about 6 weeks. Then term is going to be the period of pregnancy between 37 to 40 weeks. Preterm is the period of pregnancy before 30 completed weeks of gestation, and postterm is after 42 weeks of gestation. Then gestational age is just simply the length of the pregnancy after the first day of the last normal menstrual period, and usually we are going to be expressing it in weeks. All these definitions are very important because we use these things to summarize our patients when we're presenting these cases. Then remember that this is based on the date of the last period, not the date of conception. So because of this assumption that we make, so a person is going to be generally considered at least 4 weeks pregnant by the time they actually miss their period and they actually do a pregnancy test and it comes out positive. Then fetal lie is going to be pretty much the relation of the long axis of the fetus to that of the mother. So it could be longitudinal lie, which is 99% of the time at term or near term births. And remember that here the fetus and the mother are in the same vertical axis. So it can be either vertex, where the head is coming out first, or breech presentation, where the buttocks or any other part is coming out first. Then you can have the transverse lie, where the fetus is at right angles to the mother. Oblique lie, where they're at 45 degrees. This is rather an unstable lie and actually can convert to either a transverse lie or can convert to a longitudinal lie. And when you talk about presentation, it's just simply the portion of the fetus that's going to be overlying the pelvic inlet. And remember that the presentation and the lie usually are going to be determined roughly after 28 weeks. So before 28 weeks, it's not really so reliable for you to actually even present these things in your cases. So if the lie is longitudinal, then the presentation is cephalic. If it's the head, vertex presentation is the most common type of presentation, where the posterior fontanelle is a presenting part. You may sometimes have breech, the buttocks, a brow presentation, or a face presentation. If it's a transverse, it may have shoulders, back, and even the abdomen. Then of course the presentation can also be compound. For example, more than one anatomical part is presenting, for example, the head and an upper extremity, the head and maybe a hand. Then fetal engagement is just simply the largest diameter, which is the biparietal diameter, which is about 9.5 centimeters of the head through the plane of the pelvic inlet. So remember, this is going to be occurring much later in pregnancy, and clinically, if we say that the presenting part is at 0 station, it means that the head is thought to be actually engaged in the pelvis. So generally, if we actually do an abdominal examination, it's the head that is or the portion of the presenting part that only leaves about 2 finger breadths or less above the pelvic brim. As you can see, you're placing your fingers here and seeing that the space between the pelvic brim and the presenting part, as you can see, there are only 2 finger breadths. So this head is actually engaged. So remember that engagement is determined by palpation of the presenting part of the occiput, and then of course the fundal height decreases at term due to engagement of the fetus. Then there are some important things that I want you to include in your presentation of the cases. I'll show you a very nice example of a well-presented case. It's of course a hypothetical case. So gravidity, which I've already explained, parity, the duration of the pregnancy in weeks, the fetal lie if it's appropriate, the fetal presentation if it's appropriate, the engagement if it's appropriate. Note that fetal lie, presentation, and engagement are part of examination. Then the disease in the current pregnancy, if it's pregnancy induced or it's pregnancy associated, any medical or surgical conditions that may be relevant, and any previous disease that may affect the management, whether medical or surgical. If they've had prior C-sections, for example, it can affect how you're going to be managing these patients ultimately. So when you're presenting a case, you're going to be actually including details of who the woman is, what she is doing at the hospital or clinic, her name, of course in initials, her age, social and marital status, gravidity, parity, gestational age, the residence, clinic attendance, whether it's a self-referral or a hospital referral, then the presenting complaint and the duration. So here's an example. Before we actually go to the example, the examination. So you should include important examination findings such as the general inspection, abdominal inspection. You describe the uterus as well, including the symphysiofundal height, the number of fetuses, the presentation, the engagement, the lie core, and assessing the fetal heart rate. So here's an example. So we have Mrs. NK, who's a 26-year-old married nurse and a prime gravida. PG just stands for prime gravida at 35 weeks of gestation by dates. Of course, you can actually talk about pregnancy dating. I'll leave a card right here that you can click to actually look at how we can actually date pregnancy and calculate the gestational age, the expected date of delivery. Head over there right now to check it out after the video. I'll also leave it tagged at the end of the video. Then this woman was referred from Chilenje Clinic this morning for antepartum hemorrhage. So I've already noted the initials, the names of this person, the age, the social status of this person, even the occupation, the prime gravida, the gravidity and the parity, and the weeks of the pregnancy and how this was determined, and the reason why they were referred for antepartum hemorrhage. So they give a 1-day history of PV bleeding, that where they changed about 3 pads in 24 hours with 1 heavily soaked with clots. And remember, the patient is not currently bleeding at the time of the presentation, at the time of examination. So there is a positive history of abdominal pain, though the patient is able to perceive the fetal movements. There's no history of trauma or hypertension in pregnancy. Her BP on admission was 120/80, pulse 84. and you can even include the respiratory rate, because vitals are very, very important, especially in a patient that's bleeding. You want to assess the hemodynamic stability of this patient. So in examination, there was a single intrauterine fetus. Symphysiofundal height was 34 centimeters, longitudinal lie with vertex presentation, fully engaged with adequate liquor. Then frequent uterine contraction and uterine tenderness was noted, with a fetal heart rate of 135 beats per minute. Vaginal examination and speculum examination were deferred as the patient was still pending an obstetric scan, though a first trimester scan did not show any significant abnormalities. So did the other subsequent scans. So our urinalysis, our FBC, and our baselines were largely unremarkable. The patient has currently received 500 ml of Ringer's lactate, 2 units of FFP, and they are waiting 1 unit of whole blood, and of course to be taken for the obstetric scan. So this is like in the background of a patient that has come in, and you maybe are doing your post-admission round, and you have called your consultant, you have called your boss, and you want to present this case. Note how I've started off with the demographics of the patient. I've started off with the details of the pregnancy, how far along the pregnancy is, where they're coming from, the presenting complaints of the pregnancy, what has brought them there, and any details on the presenting complaint. Just a small expanding, it's like a summary of the entire case. So I've also included the important things that the consultant might want to know about the patient, any significant history of hypertension or trauma, and such that whenever you look at this example that I've read to you, you should be able to have a diagnosis in your mind. You should be able to know how we're going to manage the patient further. So it's pretty much demographics first, then you're going to be going to the presenting complaints and any significant things in the history, examination findings, what you have done on the investigations or what you're going to do on the investigations, as well as what has been done for the patient. In this way that you're presenting your patients like this in obstetrics and gynecology, your consultant will find it very easy, and even your seniors will find it very easy, because you tend to deal with them quite a lot, because most of these patients are actually considered as delicate patients, because it's a specialty where you're dealing with more than one life at a go. I really hope you enjoyed this very quick video on how to present obstetric patients. If you did, consider subscribing so you never miss such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.